While sitting in a surgery OPD, we often get patients who complains of burning sensation in the mouth, which is present for a long duration. These patients often have a history of using tobacco products like smoking cigarettes and BDs and even chewing tobacco for a long duration. So an oral examination becomes important for these patients. When we do an oral examination, we usually see such white flat lesions on the mucosa. It can be buccal mucosa, undersurface of the tongue, lateral border of the tongue, and even soft or hard palate. When such a lesion is revealed, we get very serious about it, as this type of lesion can be a premalignant lesion called leukoplakia. A premalignant lesion is any lesion in which the tissue is already morphologically altered, which means there is higher chances of malignancy occurring within these morphologically altered tissues. At this point of time, we should be aware that there is another condition called as oral candidiasis, which can present with such whitish plaques on the mucosa. Nothing to worry about, as it is relatively easy to differentiate leukoplakia from oral candidiasis. In case of oral candidiasis, the whitish patch can be easily scraped off with a scalpel or a gauze piece, whereas in case of leukoplakia, the whitish lesion cannot be scraped off. So with this introduction, we will take a look at various aspects of leukoplakia and how to deal with it. Before we start anything, we need to have our basics absolutely clear. We have to know that leukoplakia is a clinical term and dysplasia is a histopathological term, which means that a clinician will make a diagnosis of leukoplakia on clinical grounds and take a tissue for biopsy. This tissue biopsy will be analyzed by the histopathologists. Under a microscope, the histopathological features will be analyzed and presence of dysplasia will be commented upon. Dysplasia is presence of abnormal cells in tissues. The concerned histopathologist will not be able to give a diagnosis of leukoplakia, as leukoplakia is a clinical diagnosis and not a histopathological one. So it must be clear that leukoplakia is a clinical diagnosis and dysplasia is a histopathological diagnosis. Coming to the definition of leukoplakia, the definition of leukoplakia has evolved over time. Currently, WHO defines leukoplakia as a predominantly white lesion of the oral mucosa that cannot be categorized as any other definable lesion. The significance of this definition is that before we term a particular lesion as leukoplakia, we must rule out other causes which may cause such a whitish patch. The other causes may be benign and easily treatable, and leukoplakia, on the other hand, is a premalignant lesion and therefore should be taken more seriously. Before we understand the management of leukoplakia, we must know certain clinical features of this condition. These informations will help us to make a clear-cut clinical diagnosis. Leukoplakia is a condition which is more commonly seen in males who are above 30 years of age. However, some females can get affected by it too. These patients usually have a chronic history of tobacco chewing or smoking and alcohol consumption. Additionally, if these risk factors are absent, then we must look at other causative features causing chronic irritation of the oral mucosa, like sharp tooth, ill-fitting dentures, and stuff like these. Most important aspect of treatment of leukoplakia is cessation of tobacco usage and alcohol. And if factors other than tobacco usage is present, then those factors like sharp tooth and ill-fitting dentures should be dealt with for proper management of leukoplakia. Based on clinical appearance, Leukoplakia can be divided into two groups. They are homogeneous leukoplakia and heterogeneous leukoplakia. Homogeneous leukoplakia has an uniform appearance, as we can see in the photograph. We can observe clearly that they have a very thin white appearance. So this is homogeneous leukoplakia. Heterogeneous leukoplakia, on the other hand, have non-uniform appearance, as the name suggests. Speckled leukoplakia is one such variant. If we take a look at the photograph, we can observe that it is a mix of white and red. However, the surface is predominantly white. So speckled leukoplakia has a mix of white and red with a predominantly white surface. Take a look at another photograph of speckled leukoplakia. Just like the other image, here also we can observe red and white mix with a predominantly white background. After we have seen what homogeneous leukoplakia and speckled leukoplakia looks like, we look at another variety called as verrucous leukoplakia. Verrucous leukoplakia is another type of heterogeneous leukoplakia. It has got an elevated proliferative or corrugated surface appearance. Here I must mention a subtype of verrucous leukoplakia which is called as proliferative verrucous leukoplakia. Proliferative verrucous leukoplakia is a subtype of verrucous leukoplakia characterized by an aggressive evolution, a multifocal appearance, which is resistant to treatment. It shows a higher degree of recurrence and a high rate of malignant transformation. Lastly, we take a look at nodular leukoplakia. Try to note the pinhead-sized white nodules which are scattered on an erythematous base. These have greater risks of malignant transformation when compared to the homogeneous type. It is often associated with epithelial dysplasia or carcinoma and requires detailed microscopic assessment and regular follow-up. The importance of proper selection of the area to be biopsied and the close teamwork between a dentist and oral pathologist is the basis of providing an accurate final diagnosis. Lastly, we come to the treatment of leukoplakia. Leukoplakia may be potentially malignant, or in a small number of cases, it may already be carcinomatous, and thus both behavior modification to eliminate risk factors and active treatment of the lesions are indicated. Patient information is an important aspect in management, and removal of known risk factors like tobacco, alcohol, betel nut chewing, and trauma is a mandatory step. Up to 45% of leukoplakias may regress or totally disappear if tobacco use is completely stopped. Leukoplakias induced by smokeless tobacco may also resolve if the habit is stopped. Previously, for the treatment of leukoplakia, watchful waiting was used when excision was only done when signs of cancerizations appeared. However, this practice is currently unacceptable since even leukoplakias that show only dysplasia on prior biopsies, if excised, may contain carcinomatous foci. Thus, a reasonable initial approach to the management of leukoplakias is the removal of etiological factors coupled with simultaneous antifungal therapy. If this does not produce good results within 3 weeks, surgical excision and histopathological examination of the whole specimen seems to be the most rational next step. Coming to surgery, surgery is the obvious option for the management of leukoplakia because after surgical excision we can obtain the histopathological specimen and we can look at the specimen and find out if any carcinomatous changes have come up, and we can also get a good idea about the margins. Resection with a scalpel or carbon dioxide laser is probably the most effective and safe means of removing pathological tissue, because with scalpel and carbon dioxide laser we do get a histological specimen. However, with the use of cryosurgery or coagulation or laser vaporization, we do not get a histopathological specimen for evaluation. Resection of the lesion with a scalpel or carbon dioxide laser is preferred, as these techniques causes less postoperative scarring and postoperative pain. We can take a look at the photographs given over here, and we can observe the preoperative and postoperative photograph of leukoplakia lesion excision by a scalpel. Finally, coming to laser excision, it is usually done with a carbon dioxide laser, and it seems to have an advantage over the use of scalpel, as there is less intraoperative bleeding and there is reduced need for mucosal or dermoepidermal flaps. We can see clearly how carbon dioxide laser is effective in removing leukoplakia from the lateral border of the tongue. Post-operatively, complete epithelialization of the surface can be seen. With this, we come to the end of this session on leukoplakia. Thank you.